So welcome back, everyone. I'm going to introduce Professor Brown. Emery and Brown is the Edward Hood Taplin Professor of Medical Engineering and Computational Neuroscience at MIT, the Warren Zapol Professor of Anesthesia at Harvard Medical School, and an anesthesiologist at Massachusetts General Hospital. He received his BA, MA, MD, and Ph.D. degrees from Harvard University. His experimental research has helped define the neuroscience mechanisms of how anesthetic work. Actually, his statistics research developed statistical and signal processing methods for neuroscience data analysis. Professor Brown is a member of American Academy of Arts and Science and the U.S. National Academy of Inventors, National Academy of Medicine, National Academy of Science, and National Academy of Engineering. It's truly an honor for me to talk with you and have you with us. Please join me to welcome Professor Brown.
Oh, great. Well, thank you very much, Mohammed. Ali, also, thanks for the invitation and this chance to talk about my work in the Sharif Cognitive Neuroscience Seminar. It's a real pleasure. So I've entitled this General Anesthesia, Neuromodulation, Altered States of Arousal. And what I'll do is I want to acknowledge my colleagues before I begin. So Patrick Purdon from Mass General Hospital, Nancy Coppell, who's a mathematician at Boston University, Shuna Keju, who is an anesthesiologist at Mass General, who's now the chair of anesthesiology there, Ken Salt, anesthesiologist at Mass General Hospital, Laura Lewis, who's one of my PhD students, is now a professor at Boston University, Marusa Naranjo, who's an anesthesiologist in Mexico in Lerida, and Miriam Senechi, who's one of my PhD students, who's now a faculty member at professor out at USC in California. Sheneng Ching, one of my former postdocs, who is now at Washington University. Ahmad Eskandar, neurosurgeon, who's now at Einstein in New York. Jacob Donahue, MD PhD student, who is at Harvard Medical School now, finishing up medical school. Suresh Chakravarti, who's one of my postdocs, and Sid Cash, who's a neurology colleague. So this is the outline that I'm going to follow. I'm going to tell you a little bit about anesthesia-induced slow delta oscillations. And then I'll talk about what I call multimodal general anesthesia. And then I'll show you some work on closed-loop control and also reanimation. Anesthesia is all about turning the brain off. And so one of the things that we're doing to try to improve anesthesia is to turn the brain back on, because very often the brains of patients don't work after anesthesia. And I'll talk about this in the context of COVID-19, because right now patients are having to be ventilated for extended periods of time, sometimes as long as three weeks or if not more. And when they wake up from having had so much anesthesia or having these profound states of brain inflammation, they don't wake right up. And one of the ways, and we're sort of thinking about ways of giving the drugs in a different way, but also maybe turning their brains back on. So what is general anesthesia? So I'm going to start with the definition. General anesthesia is a drug-induced reversible state that consists of these four behavioral conditions: antinocioception, unconsciousness, amnesia, akinesia. So antinocioception is I'm using a technical term here because what I want to distinguish between is, when we first wrote this definition, this is the reason I put a star there. We didn't say it this way. We actually said analgesia, meaning you take away pain. But pain is the conscious perception of something that hurts. Whereas if you're unconscious, then your systems can be activated. Let's say your pain systems can be activated, but you won't consciously perceive it. We could see a physiological response. Maybe your heart rate and blood pressure go up. Perhaps we see inflammation form or this sort of thing. So antinocioception means we have control of the nociceptive system while you're unconscious. And in addition to having these states, we must have stability and control of the physiological systems. And reversibility is key because we bring you into the state, and once the surgery or the invasive diagnostic procedure is complete, we bring you out. So drug-induced reversible state. And I put down here that it is really no mystery how anesthesia works. And the two-sentence summary is the way the drugs work is they create oscillations in the brain circuits. These oscillations essentially hijack the brain circuits and they impede the ability of different parts of the brain to communicate. And that's what I'm going to show you starting now. All right. And one of the things I'm going to show you is that pretty much all the anesthetics, one of the key features is they produce slow delta oscillations, meaning oscillations that are between 0.1 to about 4 cycles per second. So to introduce this idea, I'm going to start with a diagram that's based on work that was done by Frederick Breme, who was a Belgian neurophysiologist. It goes back to around 1935. And even though this is a human brain, Breme did these experiments in cats. And what he did was, in the first set of experiments, he transected the spinal cord here. So separating the spinal cord from the brainstem and the brain. And when he did that, he got what he termed the encephale isolé, so the isolated encephalon. And when he measured the EEG on the animal's head, he saw an EEG pattern here, as you see, that looks very much like an awake EEG, right? Then he did a second set of experiments in another set of cats in which he transected the brain here. So now separating the brain or the cerebrum from the brain stem. So the brain stem and now the spinal cord are intact. And when he measured the EEG on the animals in this case, he got these very large slow delta oscillations. And he called that the cerveau isolé, sort of like the isolated cerebrum. So from this work, this is some of the first hints that there's something in this part of the brain that has to do with arousal that's keeping the brain in an awake state like this. And what we now know is that the major arousal centers are sitting in this part of the brain, in the brainstem, primarily in the midbrain and pons, and they travel up from here and go to the thalamus, the cortex, and they create arousal. And when you take those the brain here as Breme's principle. So I just want to apply it to a few of our anesthetics. So let me show you this about Propofol to begin. Propofol is our most used anesthetic. And it's a drug that we use because it rapidly induces unconsciousness. And if you provide it as an infusion, then someone will stay unconscious, the whole time until you turn the infusion off and the effects of the drug wear off. And so in our operating rooms, we can put EEG on patients to record the effect of the anesthetics on the brain. In fact, it's a standard part of my practice. It's been a standard part of my practice since 2011. And so you have 4 leads. So you can see the 4 leads here. So this is one on the left, one on the right, a second one on the left, a second one on the right. And this is a lady that I took care of. You can see it was back in 2013. She's about 60 years old. She weighs about, I think, 80 kilograms. And she's going to have thyroid surgery. And I'm going to give her just a bolus dose of Propofol. I'll give her 150 milligrams of Propofol. And let's just watch what happens to her brain as she receives the Propofol, how her EEG responds. So we just started injecting the drug. And now what you're going to see in just a second, you're going to see a lot of noise. And the reason the noise is there is because the Propofol burns when it goes in. So she's tensing up her arms. You can see some noise there appearing, like in the bottom trace. Now across all 4 leads. That's actually going to be good from a pedagogical standpoint, because what you're going to see is you're going to see the moment of the drug effect. Watch right here, right now. See those oscillations? Those are beta oscillations, 12 to 16%. Now the larger slow oscillations. Her brainstem is inactivated. She lost consciousness. She stopped breathing at this point. We have to take over her breathing for her. And now look, it's going to go flat and then burst and then flat. Okay. So what am I showing you? I've shown you these various states here. So this is the way she looked when she was awake. And notice the size of the oscillations. This is about 5 microvolts. And then she skipped over this state. We didn't see this paradoxical excitation. But we saw this state here at C, which was these regular, what we call beta oscillations. And that's about 12 to 16 cycles per second, right? So this is a state of sedation. In other words, if I had wanted to give her anesthesia or sedate her so that she could have, let's say, a biopsy of some sort, or maybe a colonoscopy, then this is where I would titrate the drugs just to this state here. But because we gave her a bolus, she went right through that state. And she went from there all the way down to here, where you saw those large flow oscillations come on. And that's the point at which her brainstem became inactivated. And we saw that, again, following Bremé's principle. And the clinical signs of that would be her eyes would fix in the midline. She would stop breathing. Remember, the control of the eyes is the eye muscles is in the nuclei and the upper part of the midbrain, and I'm sorry, the upper part of the pons and also in the midbrain, and also the breathing circuits are in the lower part of in the medulla and the upper part and the lower part of the pons. So she would stop breathing at the same time you see your eyes fixed in the midline. And then here she went to the state of burst suppression. This is a very deep state which the brain is completely inactivated. And between the bursts, so it bursts and then it's flat, and then between the burst, it's actually flat. So we saw all these states here. So this is why you can think of anesthesia as a drug-induced coma, because the states that you would see, like I'm showing you here in D through G, are the same states that you would see if someone were in a coma because of a traumatic head injury, or because they had, maybe a hypoxic event that, left the brain without oxygen for an extended period of time. And so these are the states that you can generate them with anesthesia. And this is the state that we would try to achieve in her and maintain with propofol. You can see it has a low frequency oscillation, about 2 hertz or so, 1 to 2 hertz. And then there's a higher frequency oscillation, which is at 10 hertz, or which we call an alpha oscillation. So it's a combination of two. So that's a typical signature for propofol. And D is the state where we would try to maintain her so that she'd be adequately unconscious to have her surgery, but not so deep that, it would be excessive, right? So let me just show you this from another perspective. So these are slow oscillations that are being produced by propofol. And we've looked at these in a number of situations in volunteer subjects, and also these are some pretty unique data. They're recorded from patients that have electrodes implanted in their brains because they have seizures. So these are patients that have had seizures for a number of years. They failed medical therapies. And so now they've come for surgery because the surgeon is going to remove the seizure focus. So the way you identify the seizure focus is the patient comes in, you anesthetize them, they implant these electrodes like I'm showing here, grid electrodes and microelectrodes, and they use them to locate the site of the seizure foci. So to do that, they implant the electrodes, and the person stays in the hospital for 5 to 7 days off medications. When they've seized enough, they bring them back to the operating room to remove the electrodes, and then they'll eventually have the surgery. So when they come back the OR the second time to have the electrodes removed, you have a natural experiment. You have a situation where you have someone who has electrodes in his or her brain, and which means that you can actually see what the neurons in the brain are doing as you anesthetize someone. And so these are the local field potentials. So the field potential is recorded, and the colors follow the colors here on the surface of the brain. So this person had these electrodes placed over the temporal lobe. And here's what the neural spiking activity is doing. So this is a neuron that's sitting next to the red electrode. So that's where the person looked when they're unconscious, sort of nice kind of desynchronous waves when you're unconscious. And then look what happens here. You give when the person is unconscious under the propofol, you see the large slow oscillations like I was showing you earlier and you saw appear in the video. And then look here, you see these periods here. So here's that same neuron. Now it can only spike in a very limited window. It can only spike now, sort of like roughly every 2 seconds, 2 to 3 communicate, then you're in a state like this. It's going to be much more challenging for the various parts of the brain to communicate, because in a given areas, the neurons can only spike at certain times. And the other thing too that I just want to point out is how large these oscillations, actually are. I'm just going to go back here to this slide here just to make this point. So as I said, this was 5 microvolts here. And then by the time you're down here in an adult, these are 20 to 50 microvolts. In kids, they can be as large as 1,000 microvolts. So what you're seeing is the effect of the drug taking over, the circuits and generating these very, very large oscillations, which relative to normal are quite abnormal, and they control dramatically when the neurons can spike. And if the neurons can't freely spike, it's going to be very difficult for them to transmit information. And just to illustrate that point here, here's some recent work from the experiments that I mentioned Jake Donahue has done with Earl Miller. So these are recordings from an anesthetized monkey, and the monkey has been anesthetized with propofol. And over here, you can see these 4 brain regions. So this is the frontal eye field and the ventrolateral prefrontal cortex. So 2 areas essentially in the front of the brain. And then the posterior parietal cortex and the superior temporal gyrus. So about halfway back and then a little bit further back, kind of in the, not quite fully occipital, but more in the parietal area, all right? And these are color-coded. So each dot is the neuron spiking. And then it's color-coded based on the region that it's coming from. And what you can see is that the spiking when the animal is anesthetized is very, very sparse. In fact, you see these large gaps in here where there's no spiking going on. So these are like those very large slow oscillations. They're all across the brain. And what they're doing is they're impeding the ability of the various parts of the brain to communicate. So we think that this is one of the primary ways through which the drugs are inducing, a state like unconsciousness by impairing communication and also essentially just shutting down spiking activity in general. This is a very large drop in spiking activity. Like the average rate here is like 1 to 2 spikes per second, whereas normally these brain regions will be spiking about 8 to 10 spikes per second. And so those are, you're seeing the slow oscillations from propofol. If you're in the operating room and you could look at the spectrogram, and this is actually from a patient that I took care of, a young woman who is about 19 years of age. She was having a small procedure. And so I'm showing you now the EEG here in time on this axis, frequency on this axis. And you can see here, so here's where we administered the drugs. And then you saw this pattern of this 10 hertz oscillation here and the slow oscillation basically at the same time. And we're maintaining it because there's an infusion of propofol running the whole time here to maintain these oscillations. So this is the classic signature of propofol when you look at its spectral content. It has, as I was showing you earlier, and this state has this 10 hertz oscillation, so a relatively high frequency oscillation, and the slow oscillation. And so this oscillation here rides on top of this one. And I showed you something about the slow oscillation. I didn't show you much about the 10 hertz oscillation. Perhaps we can get back to that in the discussion. But the key idea is that we can maintain, as you can see when the person is well anesthetized. So we know that this pattern is associated with propofol induced unconsciousness. And it's not only we know as a pattern, but we actually know the neurophysiology behind it. We think that this represents an oscillation going back and forth between the thalamus and cortex. And you saw what this oscillation here, the slow oscillation, looks like across the brain, like in the case of the animal. It's basically breaking up the various regions, making it harder for them to communicate. And so this is just looking at what the circuitry looks like. So remember I said, if you have a slow oscillation, you should think brainstem. And I just drew the anatomy out here of the brainstem, which is the anatomy that's relevant for the slow oscillation with propofol. So this is the preoptic area of the hypothalamus that I'm pointing to here. And it has projections onto all the major arousal systems, nuclei in the brainstem here. So locus coeruleus, dorsal raphe, ventral periaqueductal gray, lateral dorsal tegmental area. So when you give propofol and it travels up to the brainstem here, it hits these sites here, and these are inhibitory projections. And propofol works by enhancing GABAergic inhibition. I should have said that before. So it enhances this GABAergic inhibition. So it's going to shut down the brainstem. And what are you going to see if you measure the EEG up here? You're going to see slow oscillations, again, following Bremé's principle. But also, it doesn't just act there, it acts in the thalamus because there's a large inhibitory network around the thalamus called the thalamic reticular nucleus, as well as inhibitory interneurons in the thalamus, as well as interneurons that are in the cortex. So it's having its effect everywhere across the brain and central nervous system. But one of the things that's occurring is you're having this very large hyperpolarization of the cortex, which adds to the slow oscillation, as I said, again, is a major contributing factor to the patient being unconscious. And this is just to show you the same idea for a couple of other drugs. So this is dexmedetomidine. And dexmedetomidine is the anesthetic whose dynamics looks the closest like anything relating to sleep. So if you look here, for example, when you give a low dose of dexmedetomidine, you get something here in the 10 hertz range, or the 9 to 15 hertz range, which are what we call, they look spindle-like. You can see here they are in the time domain, these sort of little 9 to 15 hertz blips. They kind of go in, disappear, come out again. That's why they look sort of more feathery. They're quite different from the 10 hertz oscillations that I was showing you here, which are totally continuous and sort of nonstop. These are sort of more evanescent. And then you also see like slow oscillations. And this would look very much, if I hadn't told you that this was induced by dexmedetomidine, you go, oh, that looks very much like non-REM stage 2 sleep. And indeed it does. And then what happens is as you give more dexmedetomidine, you actually inactivate more of the brainstem, and you just get large slow oscillations. And so again, we're going to apply Bremé's principle. If that's correct, it says that there should be targets in the brainstem where this drug is working. And that's certainly the case. So dexmedetomidine works by blocking the release of norepinephrine from adrenergic circuits or projections that come out of the locus coeruleus. So here's the locus coeruleus, and here are these projections. So they go to basal forebrain, they go up here to central thalamus, they go to the preoptic area of the hypothalamus, and they go to cortex sort of diffusely. So now block the release of the norepinephrine. In this particular case, it's going to take away the excitatory inputs going directly to cortex, those that are going to thalamus, and it's going to take away those which go to the basal forebrain. And then here what it does, it disinhibits. So it takes away this inhibition, which is sitting on the preoptic area, and it comes here and turns off, it activates. So that's going to activate these other inhibitory pathways. So all of that is going to be a lot of inhibition coming from the brainstem, which is going to show up again as hyperpolarization, or at the deepest levels, very profound slow waves down appearing on the EEG. So again, certainly follows Bremé's principles. And then here's another illustration. This is probably my most favorite example. It's nitrous oxide. And just to sort of take you through this, we still use nitrous oxide in our hospital, although a lot of places have stopped using it. And one of the ways we use it is during a case, towards the end of a case, we'll often switch over to nitrous oxide because there's a faster wake up from nitrous oxide relative to like one of the inhaled drugs. So this is an inhaled drug, and this inhaled drug is isoflurane. And I didn't say it earlier, but isoflurane is one of the ethers. And so ether was the first anesthetic that was discovered, and we still use ethers today. We've made them, less flammable, a little more potent by changing the molecular structure a bit, but they're still fundamentally ethers. So you can see it's running here, and here's a typical pattern for an ether anesthetic: a 10 hertz oscillation, an additional theta oscillation here, and the slow and delta oscillation pattern. And now what's going to happen is we're going to turn on nitrous oxide at about 60–70%. We're going to turn down the isoflurane. And then, so nothing happens immediately. You start to see, it looks like right here, you can see like this, the 10 hertz, so like the oscillations from about 4 to about 10 hertz are breaking up. They're becoming weaker. And then all of a sudden, boom, they just drop to these very large slow oscillations. And look at this, it's just huge. And then those slow oscillations disappear. They come up to these sort of high frequency oscillations. And so these slow oscillations look like this. In fact, these are some of the largest slow oscillations that are actually produced. They're way larger than the ones I was showing you earlier for propofol. They're larger than the ones that you see basically during slow wave sleep. And then here's this period over here where the person is flipped into this sort of more maybe gamma type or high beta oscillation. So what's happening here? So it's producing these mega slow oscillations. Let me just show you what they look like on the monitor. I'll come back to the mechanism. This is what it appears like in the operating room. It looks like these were drawn by a computer, but they're like totally in sync. They're like almost perfect sine wave. You can count the period. So you have 1, 2, and the period from the amount of time from here to here between the dotted lines is 1 second. So you see sort of 2 full cycles. So this is a perfect like 2 hertz, 2 cycles per second oscillation. So what do we think is going on? Well, again, so we'll apply, Bremé's principle. So that suggests that there should be some effect here in the brainstem where you're taking away, taking away excitatory inputs going to the cortex. And so the candidate sites here are the parabrachial nucleus and the medial pontine reticular formation. These are very strong glutamatergic projections that go to central thalamus to the basal forebrain and from there on up to cortex. And we think that the mechanism through which nitrous oxide works is by blocking, acting at NMDA receptors and blocking, these excitatory inputs. So again, if you take away this excitation coming from the brainstem, you see these large slow oscillations. What's interesting about this is that they're transient; they don't last. I mean, after we first saw this, we went back and studied this in detail, and we found 19 cases where it had happened. And the average time, length of duration of these slow oscillations is about 6 to 8 minutes, and then they disappear and they convert to these sort of higher frequency oscillations, which is very surprising. We don't understand the mechanism of that, but it's a very robust phenomenon. But again, slow oscillations. And then one final case, ketamine, a much used anesthetic, or a drug which is used as an anesthetic and also or anesthetic analgesic. And now it's being used as a treatment for chronic depression in low dose. And what's interesting about ketamine is if you give a low dose of it, like I'm showing you here, you actually get high frequency oscillations, right? And then when you increase the dose a bit, so if I just give a low dose of ketamine, I kept the person on a low dose of ketamine, I would see high frequency oscillations like I'm showing you here. And what we know is that occurs because ketamine at low doses inhibits inhibitory interneurons. So if you inhibit inhibitory interneurons, the cortical neurons like this one here becomes even more active. And so you end up with a pattern on the EEG that's actually quite active. And the reason it works preferentially at inhibitory interneurons at low doses is that it has to get into the channel. It has to actually get into the channel and impede the ability of the ion flow there. So because the inhibitory interneurons are much more active relative to the pyramidal neurons, probabilistically, they're going to block them over the pyramidal neurons at low doses. When you go to higher doses, so this whole trace is that of a higher dose. It's the patient receiving a higher dose of ketamine, which would be appropriate you could use it as a sole anesthetic. And so what happens then is it not only acts here at these inhibitory interneurons, but it also acts again at those same pathways that we were talking about for nitrous oxide. So it blocks, it's glutamatergic, so an NMDA glutamatergic blocker. So it takes out these sites here, and you see the slow oscillations. There they are appearing. And what's interesting is there's a dynamic that goes between the effect on the inhibitory interneurons, the effect on the excitatory neurons, the effect on the inhibitory neurons. And so that's why you actually see this going fast, slow, fast. And that's what you see here. It's going high frequency oscillations, low frequency, high frequency oscillations. And look at the high frequency oscillations, they actually have a downward chirp in them. So this is a very fascinating dynamic, which we're studying in detail now in the non-human primates and with our modeling. But the key idea is that you see these slow oscillations, which again follow Bremen's principle. And just to make this point here, the place where, one of the key places where ketamine has its effect as an analgesic is here at this first synapse in the nociceptive system into the spinal cord, which is the dorsal root ganglia projecting onto this is a glutamatergic projection. So a good component of the analgesic effect occurs here. I just want to share with you 3 other quick cases of slow oscillations. So if you measure EEG on children who are anesthetized who are under 3 months of age, you'll see nothing but slow oscillations across their brains. And it probably is because their brains are not highly developed. The thalamocortical connections that we think are necessary to see like higher frequency, like alpha oscillations and those sorts of things, are sufficiently immature that all you see is slow oscillations when the patient receives like sevoflurane. So sevoflurane is another ether, and like isoflurane, has a very similar mechanism to propofol. It enhances GABAergic inhibition. Another case where you also see large slow oscillations clinic. Oh, actually, the kids have to be about 4 months of age before you start to see oscillations other than slow oscillations. And then here, if you have older patients, they typically don't produce any alpha oscillations whatsoever. So just giving them like sevoflurane or propofol or what have you, you'll just see essentially slow oscillations. And this is an illustration of that. There's a gentleman who's 78 years old that I took care of a few years ago. Excuse me. And then here is a drug addict who had an infected arm from shooting up. And so he was in the intensive care unit, and when we brought him down to the operating room, because he had to clean his wound every 2 to 3 days and then change the dressing in the operating room, when I put the EEG on him, this is what I saw, just these very, very large slow oscillations like I'm showing you here. And at first I couldn't believe it. I mean, he was young. I expected to see like alpha oscillations, but his brain was like really quite silent. And then after sort of thinking about it for a while, I realized what was happening. So in this case here, you're seeing slow oscillations because the brain is young and immature. And here, to some, the reason you're seeing the slow oscillation is because the brain is actually aging, and the ability to generate these other dynamics is actually degenerating with time. Here, however, the story is a little bit different. So imagine even if you just got a cold, just a simple cold, you don't feel like running a marathon, you actually feel quite tired. And that's actually a physiologic effect, because the inflammatory mediators actually bind to those arousal centers in the brainstem that I was showing you, and it turns them off. It induces sleep, and because it's saying, well, basically you should probably rest. So now imagine you have overwhelming sepsis like this gentleman does here, like some of our patients do now with COVID-19 infections. And so I'm willing to bet you, in fact, I know this is the case, that their EEGs, look like this because of the large amount of inflammation that's there. And what's happening is the inflammation, the inflammatory mediators like IL-6 and IL-10 actually bind to the arousal centers in the brainstem and shut it off. And again, Bremen's principles predicts that we would see slow oscillations, and that's indeed exactly what you see. So this is actually probably an illustration of what the brains of the COVID-19 patients look like. And what makes it even worse is they're staying like this for probably 10 days, 2 weeks, 3 weeks, however amount of time that they need to be ventilated. So you can start to see why these patients have brain dysfunction after being treated for this infection, and it's taking a while in many cases for this brain dysfunction to resolve. So let me just tell you a little bit about multimodal anesthesia here. So what we do at the moment is we give anesthesia by using multiple drugs to achieve the different states. So something that can make you unconscious, opioids primarily to help with pain or nociception. The drugs that make you unconscious are sufficient to create amnesia, so we don't have to give any additional drugs there. And we may give drugs, anticholinergic drugs, which relax your muscles or paralyze the patient to make it easier for the surgeon to operate. And you see here where it says inhaled drugs. So the inhaled drugs, meaning in this case, not just nitrous oxide, not nitrous oxide, but I'm thinking more of the ethers. They're the only drugs that sort of give you all of these effects to some extent at once. So you can use just a single drug to do this. But mostly what we do is we have, something like propofol to make you unconscious, the opioids here, maybe propofol or an ether here, and then a paralytic drug like cisatracurium or rocuronium or vecuronium to, paralyze you or to relax the muscles. And then we give drugs to maintain hemodynamic, stability, to maintain blood pressure and that sort of thing, right? So we've come up with a new strategy for doing this, and we call it multimodal general anesthesia. That's fine, what I just showed you, but we figure the drug should be picked in a more principled way, and combined in a more principled way. And the neuroanatomy, the neurophysiology allows us to do that. So let me just explain this really quickly. So you need anesthesia because things hurt. So the first thing you should do is try to give drugs that block the pain pathways or the nociceptive pathways, but don't just use one. Don't just use opioids. Use multiple different drugs, all right? So if you do that, those drugs that I've sort of shown you, like looking at some of the anesthetics we've talked about thus far, they act in multiple places in the brain. And one of the things that happens with the antinociceptive drugs is they also decrease arousal. What that means is the amount of propofol or sevoflurane that you would use to keep the person unconscious gets to be reduced. So you can achieve the same state, more efficiently. So you have better control of the pain circuits because you're using multiple different drugs, each drug attacking the pain system or the nociceptive system at a different point. And at the same time, you take advantage of the fact that they're also acting on the arousal pathways. So they're decreasing arousal just by themselves. So now the amount of propofol you have to add on top of that to make the person completely unconscious for surgery gets to be less. And to do this, you have to monitor arousal and antinociception. So to monitor the arousal, we use the EEG like I've shown you. And the antinociception, we're tracking heart rate and blood pressure to make decisions about whether or not the level of analgesic drugs that's being administered is adequate. And we suggest you do the same thing in the postoperative period. So I'll just show you a few examples really quickly. So here's a woman who's 48 years old. She's having a laparoscopic hysterectomy, salpingo-oophorectomy, cystoscopy. She's about 160 centimeters. She weighs about 65 kilograms. So here are the three drugs that I'm using to maintain antinociception. So dexmedetomidine, that was the alpha-2 drug that I showed you earlier, ketamine, NMDA antagonist, and remifentanil, which is a synthetic opioid. So three different pathways I'm working through to control nociception. And then I can keep the patient unconscious with just 70 mics per kilogram per minute of propofol. So normally for a case like this rate would be up to 100 or 150. So I'm somewhere between a third of the dose or 2/3 of the dose or maybe half the dose that would be required. And just to show you what this looks like, so these are her vital signs: heart rate here, blood pressure, oxygen saturation, temperature, all quite fine. And then this is her EEG pattern. You can see I'm getting this now, this sort of pattern of, here you can see the low frequency oscillation there, and you can see the higher frequency 10 hertz oscillation riding on top. And here's the same illustration here in the frequency domain, looking at the low frequency oscillation, and here's the 10 hertz oscillation. We're getting this at a much lower dose of propofol than you would otherwise if you didn't have the other drugs, the antinociceptive drugs, there at the same time. And these are her vital signs: her heart rate and blood pressure, were rock stable. Her oxygen saturation and temperature here were actually stable too, right? And here's another illustration. This is a woman who's 77. She's basically having 4 operations in one. She's having both of her kidneys removed because, unfortunately, she has bladder cancer that's metastasized to her kidneys. It turns out she'd had a kidney transplant before, so taking out both her kidneys, she still has kidney function preserved because she has a transplanted kidney. But then in addition, they're going to take out her bladder, and they're going to then rebuild her bladder with an ileal loop, taking up a bit of the ileum and making her a new bladder. So she's basically having 4 operations. So she's about 155 centimeters. She weighs about 81 kilograms. And I use 2 drugs here to control nociception of her. I use dexmedetomidine and lidocaine, like xylocaine, and infusion of it. And look at the dose of propofol. Now it's down to 20 or 30. And again, the normal range for a case like this should be 100 or 150. This is a fifth, a third, or even less of the typical dose. And this is because, again, even just these 2 drugs here are doing a lot to decrease arousal by themselves. And if you look at her EEG, so this is her EEG, right? And I don't know if you remember this pattern, this is burst suppression. So she's flat, she's bursting, she's flat. And this is this very profound state of brain inactivation. In fact, at these low doses, her brain, I can dial back the propofol even further, if not actually turn it off for a few minutes, or maybe 20, 30 minutes, and let her brain, come back up to, a more active state. And you don't appreciate this unless you, are using the EEG to monitor in real time. But this is what typically happens with older patients. We think that they're mostly overdosed, because if you're going to err on the side of, on one side or the other, you're probably going to err on giving people more anesthesia than less, because everybody's worried about patients being aware. But in point of fact, the doses, even these lower doses, are still probably a bit too much, particularly like in this case. And here's just the final case of a woman who's 89 plus. So when patients are over 89 years of age, we can't say we're not allowed to say how old they actually are. So we just say 89 plus. So she was over 89 years of age, and she's having a laparoscopic colectomy. She's gonna have part of her colon removed. And she's about 153 centimeters. She weighs about 57 kilos. So again, a 3-drug regimen to control nociception here: dexmedetomidine, remifentanil, lidocaine. And again, a very low dose of propofol. Again, the normal range is probably 100, 120, 150. And if you look at her EEG, her heart rate and blood pressure are quite stable here. And if you look at her EEG here, you can see that she's got, the amplitude is lower, but you can see the 10 hertz oscillation riding on top. And here's what her spectrogram looks like. What's interesting is that she's not in burst suppression like the other woman was. Her alpha oscillations are weaker, but she's not in burst suppression. So it's not surprising, that she's, 89 plus, because her brain is probably even far more intact than, the woman who was 77. So what I've shown you is we have these various pathways, and we think about how the drugs, the antinociceptive drugs, work in these various pathways. They work to decrease nociception, but at the same time, they also decrease arousal. So these are the opioids, these are their circuits. This is where ketamine and magnesium would work. Here's where dexmedetomidine would work. And then here's how, lidocaine would work. Lidocaine helps reduce inflammation. And by reducing inflammation, it reduces the activation of the nociceptive pathways. So you combine these together, and then just to blow this up again, so this is going back to ketamine. So the effects of ketamine to induce antinociception are here, but because it has these other effects here in the thalamus, the projection of the basal forebrain, and also the cortex in general, then you actually get a decrease in arousal. So this is why we can reduce the amount of propofol that's necessary to take care of these patients. So this is something that I do regularly in terms of how I take care of my patients. And we're doing a study now in cardiac anesthesia to see if we can adapt these ideas to patients having cardiac surgery. And we're looking to put together a protocol to change the way that this brain dysfunction is occurring, like in COVID-19 patients, using some of these ideas to have a more rational strategy to dose the drugs for those patients, particularly since they're going to be on these anesthetic drugs in many cases for several weeks. So I'll just say something quickly about closed loop control of anesthesia. So these are 3 very well-known people who had head injuries, and they were placed in a medical coma. So what's a medical, and we're hearing medical coma, the term used a lot now in the context of COVID-19 infections, because you often hear that, we placed them in a medical coma so we could ventilate them, they'd be profoundly unconscious. But what is a medical coma? Well, medical coma is giving propofol until you see this burst suppression pattern, this very state that indicates very deep state of brain inactivation. And you hold the patient there in that state for, several days until like their seizures resolve or until they get over their COVID infection. And so, but this is done manually. The infusion of the propofol is done manually. It's not done with the aid of a computer or anything like that. So one of the things that we've been thinking about, this is a perfect situation for closed loop control, because what you can think of is, this is burst suppression. I could tell you how suppressed I'd like the patient to be. Because let's say I wanted them to be in a state of burst suppression to control seizures. And this is one of the reasons this is used, because you're trying to stop the brain from seizing. So you actually shut it down profoundly and you hold it that way for, a couple days, 3 days, or that sort of thing. But it'd be great if the computer were controlling the infusion, because it could titrate the effect to just what you needed. So here's a system where we've tested this out in rodents already. So you can set a level of burst suppression that you would like to have, and then what you do is you have a target level, and then you measure the EEG coming out of the animal, and you do some computations, a bit of signal processing, and estimate what the actual level is. So you compare the actual level with the target level, and then the controller makes a decision about how to adjust the infusion rate of the pump to receive the level of control that you would, to try to make sure you're getting the target level that you want. And so the target is actually easy to define for burst suppression, because you're either suppressed or you're bursting. So if I say I want you to be 60% suppressed, so if I have a second's worth of data here, and so you're 0.4 here and then 0.2 there, so this would be 60% suppressed. If I had you to be 90% suppressed, then 90% of the time, in that 1 second, 90% of that 1 second, you'd be suppressed, and only 10% would you be in the bursting mode. So we've done this. We've built this system. This is work that, as I said, I mentioned Miriam Shinichi in the beginning. So this is work that she did as a postdoc with me. I'll just show you a little video to show you how this works. So what you have here is the target comes on, that's the green line. So we want the animal, in this case, to be 40% suppressed. And the white line in the middle diagram is what the controller is actually doing. The upper panel is the EEG. And then the lower panel is what the pump, the infusion, how it's being changed on a second-to-second basis to maintain that level of burst suppression. And now you've jumped up to a new level. We want you to be want the rodent, in this case, to be 70% suppressed. So you can see that it jumped up and it grabbed the target right away. You can see that the EEG is starting to reach a lower level because you're more suppressed. And then now we jump up to make it 90% suppressed, or the target to be 0.9. And if you see, the pump dynamics are entirely different. What the pump needs to do to maintain control is quite different here from what it has to do when it was at 0.4 or 0.7. All right, so totally feasible. And what I showed you here, so these are 6 examples where we've done this. I showed you this example where we went up, went up, went up. But suppose what you wanted to do was you want to go up, and now you want to come down. So when you come down, you can't really, we don't have a drug that decreases burst suppression. So what the controller does is it turns the pump off for a period. It lets the level of burst suppression decline. You can see it declining here, and then it restarts the pump once you've acquired the target. So it's like the system is like a jet when it's going up, and it's like a glider when it's coming down. So we've done this over a whole range of up, down, up, down, up. So it works quite well. So using closed loop control here for medical coma would be very feasible. And again, taking care of these patients with COVID-19 infection, this would be a perfect application of this technology. So we're looking to translate this work here into clinical use. And one final thing, which is we give you anesthesia so you can have surgery. And one of the things we should do is wake you up from it. So we let the drugs wear off passively now, but my colleague Ken Salt here has been studying the idea of turning the brain back on. So I'll just show you this. So he has a rat who's anesthetized with propofol, and he has an electrode in this animal's ventral tegmental area. So this is a part of the brain which has an amazing arousal center that releases dopamine. So now what Ken is going to do, he's going to, in just a second, stimulate this area. So the stimulation's off for the moment. And now watch right here. Watch what happens when the stimulation comes on. Watch, the first thing you see is, look, see, he starts breathing like crazy. Now the propofol is still on. We haven't turned the propofol off at all. It's still running. You can see the white infusion going into his tail. So whatever is happening is overcoming the effects of the propofol, and he walks off, all right? So what is Ken doing? So he's actually stimulating here, this part of the brain, the ventral tegmental area. It drives this arousal pathway, which is a dopaminergic pathway. And it goes through the limbic system, through the past the hippocampus, and then up to the cortex. So this is a very important pathway for cognition. And we can do the same thing just by administering Ritalin intravenously. So Ken has shown that, and he's done this optogenetically as well as electrically. And so this is an idea that we're studying now as a way to bring patients back from anesthesia. And again, another potential application of this may be to help patients recover more quickly, recover brain function after COVID infections. So this is what I've shown you, that anesthetics work by producing oscillations that disrupt how the parts of the brain communicate. But one of the principal oscillations that they produce is slow delta oscillations, which specifically represent this inhibition, this sort of inactivation of sort of the brainstem and its projections up the thalamus and cortex, causing this probably profound hyperpolarization across the entire brain. But it can occur, or probably does occur, with different mechanisms depending upon the type of drug. I showed you this idea of multimodal anesthesia and how it might be a better way to select drugs and dose them so that we have the level of analgesia that we want, or antinocioception that we want, an appropriate level of consciousness, but using the drugs in a much more efficient manner. And I can tell you, one of the things that I see when I do multimodal anesthesia is the patients come to much more quickly because their brains are not as suppressed as they would be if I'd used just the standard doses of propofol or the other drugs. And as a consequence, one of the, as I was saying, this might be something which we can adapt to taking care of patients with COVID-19. And I showed you something about turning the brain back on. So both of these ideas, the multimodal general anesthesia and the reanimation, might be ways of helping to take better care of patients who require anesthesia for surgery or to be sedated in the ICU. So these are ideas that we're pursuing actively, because brain dysfunction just after surgery, not even being in the ICU, but just after surgery, is a very common problem that is getting to be more and more of an issue as our population ages, because it affects even, it's much more significant in the older population. So again, thank you very much, and I'll stop there and maybe take a few questions.
Anyone has a question, you can raise your hand. I'm making about 5 minutes. Yes, please.
Dear Professor, thank you very much for very great presentation. I have two types of questions. First and foremost, how could someone extrapolate the great experimental result of your study into the whole members of the society? And the second question is that how could we use the experimental result to contribute its finding to use it for enhancement of consciousness of ordinary people?
Well, that's a good question. And so to answer the second one really quickly, I think that people actually, if you think of the drug like Ritalin, people actually self-administer Ritalin who are in high-stress jobs, like who are stock traders and these sorts of things. And what they say is they actually feel that their brains are sharper and this sort of thing. Now, that's probably not a good idea because they're not taking it as a prescription drug. They're self-administering it. But, you know, these are the sorts of things that people have looked at for a while, using these drugs, which are effectively stimulants, to try to drive these pathways and sort of make them more, you know, make them more efficient. So that's something which is being done. And I think, you know, thinking about ways to do that or use it for patients that have brain injuries would be is something which we're interested in doing. I think the idea is here, the main thing which could be done here to try to get some of these ideas into practice is, I didn't say this, I'm glad you asked the question. One is just using EEG. Like in our hospital, even though we have EEG in every room, only 23% of the people use the EEG to take care of patients. And I think patients are suffering as a consequence because they don't get the sort of care that they could possibly have. You can make better decisions about how to dose the drugs. When you're not using EEG, you're basically dosing the drugs blindly based on convention or based on experience. And certainly in the ICU, this is something where, you know, again, using the EEG could help, you know, dose, you know, the drugs in a much more principled way. And then if you use a strategy like the multimodal strategy, like I'm talking about here, you could probably have even a much more, you know, further refinement in the way the drugs are, you know, used, both in the OR as well as in the ICU. So those are things that we're looking at very actively now.
Sir, can we go for another question? Professor, can we go for another question?
Oh, for sure, definitely, yeah.
Mr. Ahmadi, I turned your microphone on.
Hello, can you hear me?
Yes, very well.
Thank you for your thank you for presentation. I work on brain disorders, computationally brain disorders on the structural network of brain, and in some cases we're trying to simulate Parkinson's disease structural network, and in this in our simulation we see two frequency, low frequency and high frequency activity at some time. Is it natural? Is it I don't know, based on your experimental experience, is it natural? Is it I don't know what is meaning. Do you have any comment for me? Thank you.
Yeah, I mean, I do. So, I mean, I think the specific oscillations that you're getting there, I mean, we'd have to study them together to really understand why they come about. But remember, in some sense, the brain is very stereotypical. The brain does the same thing all the time. It may do it for different reasons, but it does the same thing. So one of the ways that it responds, because, or let me say it this way, the brain, and you probably understand this even better than I do since you do computational modeling, the brain is a high dimensional dynamical system with all these interconnected areas. And what happens is when you put in insults, and the insult could be me applying a drug, it could be a traumatic injury, or it could be the development of, you know, the loss of a neurotransmitter, like in the case of Parkinson's disease, loss of dopamine. What's going to happen is you're going to alter the ability of that system to generate those dynamics. And like in the case of anesthesia, what we realize is that it's going from a very high dimensional system to much lower dimensional modes. I mean, basically that's what's happening. And the modes that it's driven into, in the case of anesthesia, depends upon the different drugs that you give. You give one set of drugs, you get one set of dynamics, you give another set of drugs, you get a whole different dynamics. So it doesn't surprise me that these oscillations are there. In fact, it's very well known, like in Parkinson's disease, that you see these sort of like beta oscillations. So I think they are very, very specific signatures that represent, like in this particular case, you know, the pathological insult, just like in the case of the anesthetics, they represent the, you know, the effects of the drugs on the circuits, and also in a very sort of mechanistic specific way. And the same thing for aging. You know, at a young age, you see one set of dynamics. At an older age, you see another set of dynamics. Again, it reflects how the circuits have been altered and how these higher order dynamics are now, you know, sort of moved into lower dimensional modes.
Sir, we have another question, and I should read it because the microphone doesn't work. The question is there any way for anesthesia to anesthesize patient without any drug or hospitals doing any project to do so? If yes, I want to know, can we one day have an anesthetize one part of body like the spinal cord?
It's a good question. Yeah, I think it is possible. I think we can get anesthesia without drugs. It requires a lot more neuroscience work, but it's something that we're actually working on. You know, for example, if someone is having like hip surgery or foot surgery, you could just put in a spinal, which would anesthetize the lower part of the body. But again, that's still drugs. You're injecting drugs essentially into the endothelial space. So I think it is possible. It requires a little bit deeper understanding of the brain and which patient and how to generate it. But I think it's something that we should certainly think about, because that would certainly be a way to move away from a lot of the side effects of drugs. I mean, the drugs are really, they're miraculous. I mean, the fact that anesthesia exists has transformed surgery from trauma and butchery to, like, in many cases, a life-saving procedure. But now that we start to see the side effects, we know we can make anesthesia work. Now what we should think about is making it better, and thinking about ways of doing it or developing approaches that don't require drugs, I think, is the way to go. But that requires a much deeper understanding, I think, of the brain, which is doable, but it won't happen tomorrow.
I think that's enough for the questions. Thank you very much for accepting our invitation. It was really an honor for us, and thanks Sherry Leone for making this contact.
Oh no, thank you very much for having me. It was my pleasure. Thanks again. All the best.
Yours. We are going to have another day for our webinar, and see you all tomorrow morning at 9 a.m. We talk from Professor Mackland. Thank you so much. Good night.